Hello, my name is Dr. Haytham Tayyib. I'm an associate professor of neurology, neuropsychiatry, and behavioral neurology at the King Abdulaziz University Faculty of Medicine in Jeddah, Saudi Arabia. It's a great pleasure to be part of this meeting and this session of dementia as a growing interest in the Arab world. And it gives me great pleasure to be able to present this talk about neuropsychiatric manifestations of dementia, including pathophysiology and management. This is obviously a broad topic of which coverage is difficult in 20 minutes, so we'll focus mainly on Alzheimer's disease, on some of the relevant aspects related to other dementias as well. I have no conflicts of interest pertaining to this talk. And we can perhaps start with this case that many of the people in the audience will recognize. This 51-year-old woman who presented with memory impairment, but who also had a plethora of psychiatric symptoms, including paranoia, anxiety, agitation, expressed here, as you see, in no ambiguous terms. This is none other than the case of Auguste Deter, the first case of Alzheimer's disease described by Alois Alzheimer himself, and it has been known since then that neuropsychiatric symptoms are part and parcel of dementia syndromes, and that dementias are not just cognitive syndromes, but are laden with psychiatric manifestations. The psychiatric manifestations may in fact predate the diagnosis of dementia by years or decades, and they continue to occur across the different stages of dementia with a changing profile every now and then, in a way that happens non-linearly, unlike cognitive syndromes, memory impairment that, for example, that decrements linearly and gradually. Neuropsychiatric syndromes change unpredictably throughout the course of the disease. And they account for a significant proportion of the burden of the disease on patients, caregivers, and healthcare systems, accounting for a significant proportion of reasons of placement in long-term care institutions. The gamut of these symptoms ranges from mood symptoms, anxiety symptoms, a lot of apathy early on, for example, if you think of Alzheimer's disease, and more explosive patterns of symptoms predominate later in the disease, including agitation and aggression and aggressiveness. Of course, agitation is also seen earlier in the disease. About 20% of patients in outpatient setting present with agitation and psychosis sometimes, but later in the disease, this number rises to 70% or more. And of course, the profile is different from one type of dementia to the other, but like I said, we'll mainly keep Alzheimer's disease in mind when we talk about these things, unless stated otherwise. And for the longest period of time, the neuropsychiatric symptoms or behavioral and psychological symptoms, these are different umbrella terms used for these symptoms, they were all viewed as a unitary phenomena. And perhaps one of the significant improvements over the past couple of decades is that they have become viewed and kept more characterized into different domains of symptoms. The neuropsychiatric inventory, created and popularized by Jeff Cummings and colleagues, splits them into these different categories shown here. In addition to the ones that come to mind immediately, like agitation and psychosis, there are also symptoms that may be less explosive but are still impactful, like eating and sleep disorders. Apathy, worthy of special focus, is prevalent and maybe an insidious herald to the onset of dementias. Think of the elderly that isn't obviously depressed or anhedonic, not crying, and so on, but sits there quietly in an amotivational state of loss of interest that renders them effectively socially inert. And there are different kinds of tools to measure the neuropsychiatric burden in the dementias. In Alzheimer's disease, for example, the BEHAVE-AD was developed, and it consists of different subdomains assessing the different neuropsychiatric symptoms. It was a longer kind of test. The neuropsychiatric inventory, along with its shorter version, NPI-Q, do the same but are easier to use in the clinic setting. And there are other tools that are used to assess specific symptoms like depression, agitation, or apathy, and so on and so forth. And these neuropsychological tools are used in both in the clinic and in clinical trials. Okay, the pathophysiologic basis of neuropsychiatric symptoms in dementia are not completely understood. However, for neurologists whose minds are based on localization, it would be helpful to review some of what we know about some of these symptoms. We link depression with monoaminergic dysfunction, and we think particularly of the subgenual anterior cingulate, which has served in idiopathic depression as a target for neurostimulation. We think of apathy as a hypodopaminergic state, and we in fact treat it with dopaminergic boosters. We think of dysfunction in dorsomedial prefrontal cortical regions that are instrumental in motivational states. Agitation and aggression and psychosis are more loosely understood as dysfunctions of diffuse neurotransmitter systems, such as including cholinergic neurotransmission, dopaminergic neurotransmission, and others, and are linked with dysfunction in a wider ranging areas of cortical and subcortical structures. Generally speaking, we think that the neurodegenerative process itself leads to disruption of neural circuitry and causes the emergence of neuropsychiatric symptoms in dementia. However, we must not neglect the importance of external factors, so to speak, operating as well. These include patient-related factors such as untreated or ongoing or hidden subtle medical problems like constipation, dehydration, pneumonia, or unmet needs like pain or insomnia, and so on and so forth. There are also caregiver-related factors, including caregiver distress and burden, and environmental factors, including changes in domiciliary, stimulation levels, and so on and so forth. And these factors may indeed be instrumental in leading to the emergence of neuropsychiatric symptoms. And the realization of this is important because it affects how one might develop an approach towards managing these symptoms. So therefore now, when we come to discuss management of neuropsychiatric symptoms in dementia, we will begin the discussion with non-pharmacologic interventions, which are the mainstay first-line approach to managing these symptoms, and this is in line with numerous guidelines and recommendations of medical organizations and expert groups. It recognizes the prevalent role of those external factors that we spoke about, the patient-related factors, the caregiver-related factors, and the environmental-related factors, and argues for an individualized methodical approach to address these factors. One common way to express this is the DICE approach. The acronym stands for Describe, Investigate, Create, and Evaluate. Describe the psychiatric symptoms that you see, form hypotheses about their origins, investigate, try and prove or disprove your hypotheses, create a plan to address the causes that you think may have given origin, including those caregiver and patient and environmental factors, and evaluate the impact of your plan. This may all be intuitive, but the reason why we need it is that there is a prevalent knee-jerk reaction to simply prescribe medications to treat neuropsychiatric symptoms in dementia without necessarily addressing those external factors that are so prevalent in our population. And in addition to this individualized functional analysis and intervention approach, there are other non-pharmacological approaches that may be useful. The professionals and resources required for these interventions are not always available in some of the Arab communities, unfortunately, and many of us have to improvise in the clinic, try to give access to the benefits of these interventions. Some of the stuff that I find useful to try to get the gist of is reminiscence therapy and music therapy. And it has been shown that some of these non-pharmacologic interventions are actually beneficial with effect sizes that are similar to your pharmacological approaches. This plot is from a systematic review showing differences in standard means of scores, and you have effect sizes relatively modest in the 0.2 range. The quality of the data for the non-pharmacologic treatments is not great, but still these are interventions that may be helpful with relatively low to no side effects, and you can get a big bang for your buck. And this is a good segue perhaps to review the trials for some of the pharmacologic agents that we have for atypical antipsychotics and for acetylcholinesterase inhibitors, including donepezil and galantamine and rivastigmine, for memantine. There has been evidence that these interventions are helpful. Analgesia also helps, and we'll review some of these interventions as we go on. Antipsychotic medications have been known to help with agitation and psychosis. There are clinical trials supporting use of first-generation and second-generation antipsychotics. There's evidence that with first-generation antipsychotics for improvement in agitation and psychosis, but these are, of course, laden with side effects, including extrapyramidal side effects, prolonged QTC, and sedation and other side effects. Second-generation antipsychotics are backed with clinical trial evidence, and both in second-generation and first-generation antipsychotics, the evidence supports short-term use of these medications, beyond which benefit is doubtful. For second-generation antipsychotics, the evidence backs risperidone and Abilify, and to a certain extent olanzapine as well, as being effective in reducing scores and the effects of agitation. And there is some evidence also that they reduce psychosis itself and anxiety and irritability. Of course, there was hope that second-generation antipsychotics would be a lot safer than first-generation antipsychotics, but this remains doubtful. There is a lot of data at this point that has accumulated since 2005 that there's an increase in all-cause mortality in patients later in life taking second-generation antipsychotics, and this evidence has accumulated, leading to the FDA issuing a black box warning related to use of these treatments in this population. And the magnitude of the hazard ratio hovers around 2 times. And there are other dangers of antipsychotics in addition to dying. There's a high risk of stroke, sedation, and so on and so forth. Supporting the importance of not keeping people on these medications, and in fact they were considered inappropriate medications by the American Geriatric Society. You'll find it there in the list. So therefore, the recommendation is not to start second-generation antipsychotics unless you have to. And if you have to, you want to follow this regularly at 1 month, 2 months, and 3 months. If there's no effect, certainly discontinue the medication. If there is benefit, still attempt to reduce the dosage and attempt to withdraw the medications completely as soon as you can. And it's not like antipsychotics are the only intervention that we have, pharmacologically speaking. SSRIs may be helpful in reducing agitation scores. This is from the citalopram on agitation and Alzheimer's disease, the CIT-80 randomized controlled trials showing evidence that use of citalopram reduces agitation. Analgesia is also one of the effective interventions with a significant effect size, as I showed you previously in that graph. Use of simple analgesics, but also escalating analgesia it may indeed help reduce agitation and aggressiveness. Keep in mind that many of our patients with dementia are not able to express pain, and that there may be indirect signs that patients are suffering from pain, or there may be no signs at all. So if a patient has a good reason to have pain, putting them on an analgesia protocol may actually help. And it was demonstrated that keeping patients on analgesic protocol for a couple of months may actually lead to improvement in their neuropsychiatric scores. And our acetylcholine esterase inhibitors are actually helpful from the neuropsychiatric standpoint as well. Being on an ACHEI reduces the risk of going on an antipsychotic, and the higher the dose, the less likely that a person will need an antipsychotic. Memantine may also help a little bit with agitation, with a significant effect size as well. So the medications that we routinely use for dementia may be sufficient in reducing the burden of neuropsychiatric symptoms. Delusions as well all help with memantine, as you can see here. Anti-seizure medications have been of interest, and there has been a recent growing interest in the role of epileptogenicity in the pathophysiology of dementia, with the idea being that neurodegeneration leads to disruption of neuronal circuits, which leads to excitotoxicity and epileptogenicity. And of course, the opposite may be true, with epilepsy causing cognitive impairment in the epilepsy population. And even though anti-seizure medications have been used to treat agitation, there is really not a lot of evidence supporting the use of these medications. We know that carbamazepine and valproic acid are not. There's evidence that they're not helpful in treating people with dementia for agitation, and these other anti-seizure medications may be helpful, but there's limited evidence that they are. These various interventions were looked at by a group of international experts published by Kales et al. And the experts went through a Delphi process to try to reach a consensus on how to use these components of the arsenal to treat psychiatric symptoms in dementia. And this is how the results looked like. A thorough assessment and management of underlying causes was ranked first with unanimous agreement by the group. Solving caregiver problems came in second, followed by environmental adaptation. Hence, the emphasis on the importance of addressing the external factors that we talked about, and having individualized approaches to treating these symptoms. Citalopram comes right there in rank number 6 as perhaps the first of the pharmacologic interventions to come up, followed by analgesia and risperidone as a second generation antipsychotic, ranking last. If there is psychosis, however, the group agreed that the use of risperidone should be prioritized then. In other words, if there is no clear psychosis, one should not resort immediately to use of second generation antipsychotics. All right, a word or two about depression and apathy in dementia. Depression is not uncommon in dementia, even though it sometimes manifests in altered ways in the context of dementia, such as reduction in activities and levels of interest in various activities, and lack of sleep, or lack of eating, or hyperphagia. Truth of the matter is that we don't have effective pharmacologic treatments for dementia, for depression in dementia. Unfortunately, there is no significant evidence that our typical interventions are actually effective in reducing depression scores. Therefore, the approach should be more holistic, including psychological approaches addressing social and environmental factors. And consideration should be given in cases of severe depression to neurostimulation. ECT has been well known for years and decades to be effective in depression. Psychotic depression specifically is known to respond well to ECT, and there's initial data that it may be helpful specifically in the context of Alzheimer's disease. Apathy may be conceived of as a hypodopaminergic state, and even though there's not a lot of evidence, there are a few small trials supporting use of dopaminergic antidepressants like agomelatine. Psychostimulants may also be helpful. I can support this with anecdotal evidence on my end. There's equivocal evidence that acetylcholinesterase inhibitors may also be helpful, and there's some evidence that antidepressant SSRIs may actually worsen apathy. And I felt that this talk would not be complete without these honorable mentions. Pimavanserin for psychosis treatment in Parkinson's disease, dextromethorphan quinidine for treatment of disinhibition and impulsivity in frontotemporal dementia predominantly, beta blockers for treatment of disinhibition in traumatic brain injury patients, treatments of REM sleep behavior disorder in synucleinopathies, and perhaps, most importantly, avoidance of antipsychotic treatments in patients suspected to have Lewy body dementia. And finally, here are some of the take-home messages. There's a lot of data in the field, but quality is not always excellent. Effects of many of our interventions are small. We need to distinguish the different neurobehavioral syndromes, both in the clinic and in clinical trials. When managing neuropsychiatric symptoms in dementia, the non-pharmacologic approach is the mainstay first line, so one should always dice. Citalopram, analgesia, acetylcholinesterase inhibitors, and memantine may help you avoid neuroleptic treatment. So avoid it altogether if you can. Avoiding neuroleptics is especially important in people with Lewy body dementia, so you gotta know which dementia syndrome you're dealing with. And if you start a neuroleptic, risperidone is perhaps the best one supported by evidence for agitation and psychosis. But if you do, one must reevaluate the need for the use of the neuroleptic and withdraw it as soon as one can. Treating depression may or may not work, and neurostimulation may hold future promise, and apathy sometimes heralds the onset of dementia and should be recognized as a hypodopaminergic state and potentially even treated as such. Thank you very much. This was a pleasure. I'll look forward to the discussion.